Everyone. Welcome back to the Dietitians and Nutrition Support Podcast. Today's episode is all about feeding the critically ill patient. And if you've ever worked in an ICU, you know that nutrition support is rarely straightforward in this patient population. Between proning, sedation, procedures, hemodynamic instability, and frequent interruptions, patients often receive far less nutrition than intended. And it's not because clinicians don't know the evidence, but because the systems aren't designed to protect delivery of nutrition support. So today we're focusing on what actually works in the ICU. I'm joined by Susy Cohen, a critical care dietitian at HCA Florida Aventura Hospital, who provides nutrition support to medical, surgical, trauma, and cardiovascular ICU patients and participates in daily multidisciplinary rounds. Susy has led measurable improvements in enteral and parenteral nutrition through practical, protocol-driven interdisciplinary approaches, including implementing early enteral nutrition for intubated patients, introducing an adjusted rate-based feeding program that significantly improved nutrition delivery, and collaborating with pharmacy to ensure appropriate use of parenteral nutrition. Today, we'll talk about feeding prone patients, early enteral nutrition in the ICU, improving adequacy despite frequent interruptions, and how interdisciplinary collaboration can transform nutrition support for the critically ill patient population. This episode is grounded in real-world ICU practice and focused on outcomes that matter to patients and their care team.
Coming to you from the Dietitians and Nutrition Support Dietetic Practice Group, this is the DNS Member Podcast, where we explore topics relevant to our field. From support line content to nutrition celebrity interviews and everything in between, this podcast is where DNS members can go behind the scenes and explore the driving forces behind cutting-edge nutrition support. I'm your host, Christina Rollins. Let's get started.
Susy, welcome to the DNS podcast. I really appreciate you taking time out of your schedule to chat with us today.
Thank you so much for having me. I'm excited.
So, feeding prone patients has historically made teams nervous. So, how do you approach enteral nutrition in the prone patient population, and what helps overcome resistance, specifically in the ICU?
All right, this is a great question to start off the podcast with because I actually started my career as a dietitian back in 2020 during COVID-19 in the ICU. So this is when we really started to see a lot of proning because this is part of medical management for acute respiratory distress syndrome or ARDS. So before COVID, we definitely still used proning for ARDS, but we definitely saw more research come out during the pandemic as well, and especially in regards to feeding patients when they are prone. So proning patients is essentially when they are laying face down, and this is again part of their medical management for the ARDS, and they lay basically on their tummy for about 16 to 20 hours, and then they flip them back to supine position. So given the nature of prone positioning, like you mentioned, there is a fear to feed patients when they are in this position because we're just not used to feeding patients when they're on their tummy. But thankfully, in 2020, early on in 2020, Aspen actually came out with an amazing resource for enteral feeding in the prone position. What it did is it basically compiled all of the research that is available for enteral feeding in prone patients, and it formulated, quote unquote guidelines that essentially supports starting and advancing tube feeds to goal as tolerated in these patients, as long as they're obviously hemodynamically stable and they have a functional GI tract. And the biggest takeaway from these guidelines that were published in 2020 is two things. Number one, ensuring that the patient is in the proper position, so in reverse Trendelenburg position, to promote gastric emptying, to have, gravity on their side essentially, and having the head of the bed elevated to 10 to 25 degrees, and also considering a promotility agent early to promote gastric emptying and motility, making sure that things are moving down. And these two big things that is said in this position paper from Aspen, those are the two things that I use to personally approach enteral nutrition in pro patients. So making sure that they're in the proper positioning and considering pro motility agents early. And of course, if there are providers out there that don't have experience feeding prone patients or they're not familiar with these latest guidelines, the best thing to do and the best way to overcome resistance is to have discussions during multidisciplinary rounds, have discussions one-on-one with the provider and show them this evidence, show them that it's evidence-based to feed patients enterally when they are in the prone position. And thankfully, since 2020, the Aspen paper isn't the only one that exists. Since 2020, a lot more guidelines and papers and research have come out supporting the practice of enterally feeding patients when they are in the prone position. So this has really provided us ICU dietitians with a lot of really good resources to support our recommendations for continuing enteral feeding in the prone position. And the last thing I'll mention is that it's also super useful, and I would really recommend to have a written policy or a protocol in place that outlines, the recommendations for enterally feeding prone patients and includes any further instructions that you want to uphold, such as, whether or not your facility wants to hold tube feeds for 1 hour before and after proning, which some facilities do. But having a written protocol in place will also help further support your recommendations when you're providing them to a provider or when you're, giving them during multidisciplinary rounds.
What are some of the biggest misconceptions around aspiration risk and enteral feeding in the critically ill or prone patient population?
Okay, yeah, really good question. So continuing on the topic of prone patients, so again, due to the fact that they are on their tummy, the nature of the person lying down, face down, this is not how we typically feed someone. There is this misconception that enterally feeding or, using tube feeding in this prone position is not going to be tolerated, that it's going to be vomited, and essentially further increase the risk of aspiration. However, we know per the updated Aspen guidelines for COVID-19 that there's retrospective and prospective trials that have shown that tube feeding in prone patients is actually not associated with increased risk of either GI or pulmonary complications. So as mentioned before, you could definitely deliver, tube feeding and enteral feeding at goal in patients in the prone position, as long as you are ensuring proper positioning and considering a motility agent. So for proning, definitely, we know that there's research supporting enteral feeding. In terms of enteral feeding in ICU patients in general and risk of aspiration, there is another big myth, which I'm sure you've heard, that high gastric residuals or GRVs, it means increased risk of aspiration. Having increased gastric residuals means high aspiration risk, and therefore we should start measuring gastric residual volumes routinely and using that as a way of predicting whether or not the patient is at risk for aspiration. However, again, we know from the literature that gastric residual volumes or GRVs, they don't accurately predict aspiration, and they actually should not be used to monitor tolerance routinely because they lead to unnecessary holding of feeding, which obviously we don't want. There is really little evidence suggesting that gastric residual volume measurements are effective in reducing risk of aspiration or other pulmonary complications. So the 2016 Aspen SCCM guidelines even say, and they recommend against using gastric residual volumes as part of routine care to monitor patients that are receiving tube feeding in the ICU. And they say that if there are still ICUs nowadays where gastric residual volumes are still being measured, don't hold tube feeding if the gastric residual volumes are less than 500 mLs and in the absence of other signs of intolerance, vomiting, abdominal distension, etc. So as mentioned before, because we are a evidence-based profession, educating the team, showing them this literature is vital. It's key. It's what's really going to help drive our recommendations, because what we're doing is shown in the evidence to be a evidence-based practice, So anytime you can educate the team, show them the literature, and if, again, you can maybe have a facility protocol in place that ensures that checking gastric residual volumes is not part of routine nursing care, making sure that there are orders that exist for checking gastric residual volumes, all of that will really help prevent using gastric residual volumes routinely to quote unquote, predict aspiration because this is not evidence-based practice.
Well, I want to call out that you had implemented in your ICU an adjusted rate-based feeding program that actually increased enteral nutrition delivery from under 50% of goal to about 90%, which is a huge improvement over baseline. So what problem were you initially trying to solve with this approach?
Yes, and this is something that we were so excited about when we analyzed the data that we had collected and we saw that number. We saw such a significant increase in enteral nutrition delivery in our critically ill patients. It's something we're definitely very proud of. So in our facility, we don't use volume-based feeding. In most institutions, and this is what we do, we use continuous rate-based feeding. So you have a constant rate of feeding basically being delivered through a feeding pump hourly. So the patient is, every single hour getting a specific rate of tube feeding. And, you can assume that they're getting it for most of the day. But what do we know about feeding, especially feeding patients in the ICU, is that there can be many interruptions due to, different variables that go on in the ICU inevitably that can cause tube feedings to be turned off. And so calculating continuous tube feeding goal rates based on a 24-hour regimen will probably it probably won't be as realistic. So what we used to always do is we used to calculate our goal rates instead of over 24 hours, used to calculate them based on 22 hours, assuming that for around 2 hours per day, the tube feeds were being held. However, we collected data, so we checked our feeding pumps when patients were receiving tube feeding, and through the feeding pump, you can check how much formula was delivered to the patient in the last 24 hours. So we checked to see how many milliliters of formula they were getting in the last 24 hours, and we found that on average, 41% of prescribed nutrition was being delivered using our calculated 22-hour regimen. So 41%, it actually reflects what the literature shows is the average enteral nutrition delivery in ICUs in the US, which is around 50% or less, but obviously not a number that we want. So we saw that and we said, okay, we definitely need to figure out a way to increase our tube feeding delivery in the ICU because we want to, of course, mitigate the risk of malnutrition, which we know is associated with poorer outcomes in all hospitalized patients, but especially in the critically ill. We want to optimize their nutrition. We want to facilitate recovery. So we definitely want to get that number higher. So that's when we implemented a different adjusted rate-based feeding program, and that really significantly increased our tube feeding delivery.
Adjusted rate-based feeding differ operationally from traditional hourly rate orders? I think what most of us are accustomed to using. And why does it work better in the ICU setting?
Yeah, so after going through our different options, after we collected the data and we went through our different options to see what we can do to increase tube feeding delivery, we discussed it with the multidisciplinary team and we decided that at this time, volume-based feeding, or some people call it catch-up protocols too, it wouldn't be the most efficient technique, at least for us to implement, because there are a lot of things that go into starting a volume-based feeding program, lots of education, embedding the protocol into the EMR. So what we did is we decided to continue continuous rate-based feeding, but we adjusted it even further. So we based the goal now instead of 22 hours, we base it on 20 hours now. So this helps us further compensate for any interruptions that happen during patient care that are causing decreased tube feeding delivery in the ICU. Patients being MPO for procedures, if feeding is turned off for nursing care, for when they're getting transported to imaging, maybe interruptions for, quote unquote, intolerance. So in general, traditionally hourly rate orders are going to be made assuming that the patient has their tube feeds running for 24 hours. We did essentially before an hourly rate order, but we adjusted it and we assumed that the patient was going to have it running for 22 hours. But again, we collected the data and we saw that this was not really working. So our new adjusted method based on 20 hours, it acknowledges that continuous tube feeds, they don't run for 24 hours in the ICU due to all the frequent interruptions that are inevitable, right? But they also don't run for 23 hours, they don't run for 22, they don't even run for 21 hours either, right? So we basically calculate an adjusted goal to make sure that patients get as close as possible to their daily requirements for calorie and protein intake. And we implemented this, and a couple months after implementation, we again collected data from the feeding pumps to see how many milliliters of formula were being delivered to the patients in the last 24 hours. And we discovered that the majority of patients were actually hitting 100% of their daily 20-hour volume goal, which was really cool to see. So the average of all the data we collected, it ended up increasing all the way to 90% from that previous 41%. So it looks like on average, at least, in our institution, tube feeds are being held on average for 4 hours daily for patient care. So basing our feeding goal on a 20-hour regimen has really been very helpful. And I actually even saw that there's a study I saw, and I think more studies are coming out to show how adjusted rate-based feeding protocols, such as like very similar to the one that we implemented, how they can easily be implemented, how they're good because they prevent, nursing burnout, which can happen sometimes with volume-based feeding. And most importantly, which I was very excited to see, how it can improve nutrition outcomes. So that's very, very, very exciting. And we're very happy to see the results increase when we started implementing this.
Well, I think kind of maybe a theme of this episode or a theme of what you're doing at your institution is really thinking outside the box to get your patients fed appropriately. Because I know you've also implemented an early enteral nutrition protocol for all intubated patients. So tell us about that and what prompted that change and kind of what barriers did you encounter before you had the protocol in place?
Yeah, so early enteral nutrition. We know that the 2016 ASPEN and SACM guidelines recommend starting early enteral nutrition within 24 to 48 hours of admission to the ICU. And this is because the research shows that early enteral nutrition is associated with decreased length of stay, both in the hospital and in the ICU, decreased mortality, both in the hospital and in the ICU, decrease infectious complications, increase nutrition intake. So obviously we want to feed patients earlier when possible, right? So what do I do to promote this and what was I doing before we implemented this protocol? I go to multidisciplinary rounds every single day. We round every single day in the ICU. And I always recommend early enteral nutrition initiation for our intubated patients when it's appropriate to the ICU team. So this is something that happens every single morning. We round on all of our ICU patients and any intubated patients that, could start early enteral nutrition, obviously is part of my recommendation. However, what we really wanted to do is we wanted to make sure that we could start early enteral nutrition for patients as well that, maybe I didn't catch during multidisciplinary rounds, patients that come in overnight, patients that come in the afternoon after multidisciplinary rounds, patients that come in maybe on a weekend day where there isn't a dietitian available, because we want to prevent delay in nutrition initiation, right? We want to make sure that if early enteral nutrition can be started, that it does get started. So what we did, we discussed with ICU leadership, and eventually our early enteral nutrition protocol was born, and it was implemented back in 2023. This protocol is essentially what happens is the physicians, they order for all intubated patients, they order a ventilator order set that includes, different orders that are needed for ventilated intubated patients. And what we did is we embedded into that ventilator order set a tube feeding order that gets placed when physicians order this ventilator order set for intubated patients. And this tube feeding order gets intubated patients started on a hypocaloric, high protein formula at a trophic rate. So that way, by the time the dietitian assesses the patient, especially if it's after multidisciplinary rounds or if the patient came in overnight, by the time the dietitian sees the patient, they've already been started on a trophic rate of tube feeds. And what we need to do on our end is just make any necessary adjustments to the formula, to the goal rate, as indicated, as needed based on the patient's condition. An important thing I do want to mention, though, about this is that the doctor does need to check off the early enteral nutrition or the tube feeding order when they order that vent order set, right? Because we want to make sure that that tube feeding order is only placed when tube feeding is indicated and when it's appropriate. So for example, if the patient doesn't have a functional GI tract, or if they are hemodynamically unstable, the doctor or the provider does not have to check off. They don't check off the early enteral nutrition tube feeding order in the set. That way the patient is kept MPO and they're not started on tube feeding. But for most patients, if they're intubated and it's appropriate to enterally feed them, they can immediately get started on this trophic rate of feeding. So that way, by the time the dietitian assesses the patient, they've already been started on it. So we've implemented that early enteral nutrition to reap the benefits of it, and then we just need to make any necessary adjustments as needed.
And how do you balance the early enteral nutrition approach with concerns about vasopressors and hemodynamic instability?
Yeah, so the concern with vasopressors and enteral feeding and tube feeding is the risk for mesenteric ischemia or bowel necrosis. Because what vasopressors do is they direct blood away from our GI tract to make sure that there is adequate perfusion to the vital organs. So when it comes to feeding patients on vasopressors, some people are always concerned about, that risk of bowel necrosis, of bowel ischemia, because there's not sufficient, blood being directed to the GI tract. But the literature and the early EN recommendations for vasopressors, what it does is it basically recommends early enteral nutrition, but it varies depending on the patient's vasopressor dose. So their dose of vasopressor and their hemodynamic status. I love all the research that comes out from Dr. Paul Wischmeyer. I'm sure you've heard his name before, and he has a famous quote that I always refer to because he says that when it comes to feeding patients on vasopressors, the goal is not to feed everyone early, but the goal is to feed the right patient at the right time in the right way. And the evidence supports a very careful approach to feeding patients on vasopressors. And there's three big takeaways that I would say is that we really want to know as dietitians whenever we are approached about feeding patients on vasopressors. So the first one is that vasopressor use alone is not a contraindication to enteral nutrition. So just because a patient is on vasopressors does not mean that they cannot get enteral nutrition. So vasopressor use alone is not a contraindication to tube feeding. Number two, the dose of the vasopressor, as well as the trend of the vasopressor dose. So whether it's going up, whether it's increasing, whether it's going down, if it's staying stable, that's what we really, really want to look at and pay attention to. And number three, early trophic feeding at either 10 or 20 cc's per hour can be started once the patient is adequately resuscitated, while we look for signs of intolerance, just to, be careful. We're looking for signs like abdominal distension, unexplained elevation in lactate levels. You could start the patient on tube feeding, trophic rate, 10 to 20 cc's per hour if they are on pressors once they are resuscitated. And of course, it's an adequate dose of the pressor, which I'll talk about right now. Very carefully looking at everything that's going on to look for possible signs of intolerance, right? So to address that second point that I mentioned about the doses, so Dr. Paul Wischmeyer, he has a fantastic table in a 2021 review article, which I printed out and I have it huge in my office and I refer to all the time. I love it so much. What it does is it outlines the evidence for what is considered appropriate vasopressor dose in norepinephrine equivalents for starting trophic tube feeding or considering tube feeding in these patients. And it also outlines which doses pose significant risk for bowel ischemia if enteral nutrition is started. So with all of this information, what is the best way to approach tube feeding in these patients? I would say two ways. We want to balance tube feeding in patients on vasopressors by including maybe this evidence in a protocol, right? Having, like I mentioned prior, having this in a written policy so that we know, what the evidence says and what is the best practice to use for feeding patients on pressors, but really balancing it really well with our individualized clinical judgment and multidisciplinary communication, because all in all, besides, I analyze pressure doses myself. I analyze the trends myself to see if they've been going up, they've been going down. This is something that gets talked about all the time in multidisciplinary rounds when they're talking about the patients that are on vasopressor. So I analyze that. But at the end of the day, whether or not a patient gets started on tube feeding when they are on vasopressors will really come down to my discussion with the intensivist during rounds to determine if, given the patient's current hemodynamics, their pressure doses, everything, it is medically feasible to feed the patient enterally.
And another myth that we hear sometimes in the ICU is that enteral nutrition isn't safe for patients receiving neuromuscular blocking agents. So can we talk about the evidence behind that and how clinicians can confidently manage EN in these situations?
Absolutely. So yeah, this is another ICU nutrition myth. So neuromuscular blocking agents, they're often given to patients that are intubated to assist with ventilator synchrony. It acts on skeletal muscle. So what it does is it acts on the nicotinic acetylcholine receptors at neuromuscular junctions, and it causes muscle paralysis. It causes skeletal muscle paralysis, and this helps with overall ventilator synchrony for patients that are intubated. So neuromuscular blocking agents, they don't affect smooth muscle. They affect skeletal muscle. Smooth muscle is a type of muscle that's found in our gut. So as expected, the data shows that neuromuscular blocking agents, they don't affect gastric peristalsis, and actually tube feeding in paralyzed patients can actually reduce mortality, length of stay, and hospital-acquired pneumonia. So there's actually research to show how feeding patients enterally when they are on neuromuscular blocking agents can actually be beneficial. So clinicians can very confidently prescribe enteral nutrition safely to patients that are paralyzed, and these patients can tolerate tube feeds at goal. Of course, again, looking at the overall picture, making sure they're hemodynamically stable, that their GI tract is functional. But you could prescribe and you could feed patients enterally at goal when they are paralyzed with neuromuscular blocking agents. So it's super important in a situation where you as a clinical dietitian get pushback from a provider about starting tube feeds or advancing tube feeds for a patient that's paralyzed with a neuromuscular blocking agent to educate, 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 show the evidence, show the research, show the science, show how and talk about how this is not going to be affecting the smooth muscle in our GI tract, show the benefits with what the literature shows are the benefits to feeding patients when they're on neuromuscular blocking agents. At the end of the day, again, I can't say this enough tonight. We are an evidence-based profession, and everything we do is evidence-based. So when we show the literature, this is what's going to help us get our recommendations started and supported.
Well, last topic I want to pick your brain about another controversy that I think you've really effectively managed in your institution is parenteral nutrition in the ICU. So, how did your collaboration with pharmacy in particular help define and track PN appropriateness?
Yeah, so parenteral nutrition. What is that quote that's, in the back of every single clinical dietitian's mind? If the gut works, use it, right? We always want to reap the benefits of using the GI tract when it's functional. We want to prevent bacterial translocation, prevent villi atrophy. We want to feed our gut microbiome, support the immune system in our gut. We always want to use the gut if it's working. If it's not working, that's when we need to consider parenteral nutrition. In our facility, so I know many other facilities, it's like this too. In our facility, when a provider orders parenteral nutrition, they have to input a pharmacy consult for parenteral nutrition because in our facility, the registered pharmacists write the order and order the parenteral nutrition bag for the patient. So as you can imagine, it's extremely important for a pharmacy to work very closely with the registered dietitians to ensure, number one, that the order for parenteral nutrition is appropriate, i.e. that there's a clinical indication for parenteral nutrition that involves altered GI function. And number two, that they provide the dietitians prescribed macros, micros, fluid needs in the PN bag. So I always think about, I'm quoting a lot of people, but this is another one of my favorite quotes from Dr. Stanley Dudrick. He's the father of parenteral nutrition, and he said that the ultimate nutrition goal is to provide optimal nutrition to all patients under all conditions at all times. So the way I think about it is if we're going to be prescribing parenteral nutrition, he's the father of parenteral nutrition, you want to make sure that we are providing optimal nutrition, that we're providing exactly what the patient needs to to meet their needs at that time. So what myself and other members of the clinical RD team did is we met with the registered pharmacists multiple times, and we've gone over with them, basically parenteral nutrition 101, if you want to call it, at length. We talk about parenteral nutrition indications, potential candidates for parenteral nutrition, example candidates, contraindications to parenteral nutrition, the difference between EN and PN, the benefits of using PN when the gut is functional, things to consider when it comes to starting parenteral nutrition, complications of parenteral nutrition. So we've talked about this in meetings. I've actually presented myself to the registered pharmacists on this topic. And, not just talking about the physiology, but again, the evidence, the literature. What does the literature say? Because there's actually even literature that says that by preventing inappropriate parenteral nutrition, there are cost-saving benefits. So using all of this literature and, of course, explaining the physiology and basically meeting, with the team and educating them and really showing them what parenteral nutrition appropriateness looks like. That educational aspect of our interdisciplinary work has been really helpful. It's what's really helped us define parenteral nutrition appropriateness in our facility so that ultimately we could start tracking parenteral nutrition orders very closely and get as many appropriate parenteral nutrition orders as possible in our facility.
Well, and objectively, your efforts have been successful, right? Like your team achieved several months of 100% appropriate PN orders. So that's really no small feat. So what systems or workflows do you think made that possible?
Yeah, and this is something that we're very, very proud of, and we love our pharmacy department because really working together with them has really helped make this achievement possible. So we have two main systems in place that have allowed us to achieve consistent, appropriate ordering of PN. And both of these systems came about in place again through the meetings that we've had with the pharmacy team, like I mentioned before. And our main goal in creating these two workflows was to prevent inappropriate parenteral nutrition orders from even getting started. So in our facility, since parenteral nutrition is ordered by the provider by placing a pharmacy consult, so pharmacy, as you can imagine, is the first department to find out about a new parenteral nutrition order. So the first system that we have in place is that the registered pharmacists, they contact our team as soon as they receive a new parenteral nutrition consult. So that way the dietitian can give them the green light, so to speak, to either order it if it's appropriate, if we're recommending it, or if it's not appropriate. So that way the dietitian has the ability to know about the order and then contact the provider and attempt to de-escalate this order through either education, recommendations for tube feeding, a feeding tube placement, an NG tube placement if warranted, oral diet initiation, whatever intervention is indicated. If the parenteral nutrition is not appropriate and we can de-escalate it, we can know about it, right? So that we can have this time to contact the provider and then essentially tell pharmacy, this is not an appropriate order. I spoke to the provider already. Let's not order it. So this close contact has been a huge blessing and has really worked really great. And it's been the main driver for sure for ensuring appropriate parenteral nutrition orders in our facility. And we have another system. It's very similar. So the second system we have in place is we were able to attach a dietitian notification to that pharmacy consult for parenteral nutrition that providers place so that every time this consult is placed, we actually get an automatic printout in the dietitian's office telling us that a new pharmacy consult for PN has been placed by, X provider for X patient. So pharmacy still contacts us every single time they get a new consult on their end, but at least we get a printout at the same time in our office, so we're alerted at the same time as them. And this allows us to, make any necessary chart reviews, contact team members, etc. So by the time pharmacy calls us and they ask us for our blessing, so to speak, we've already done the necessary interventions to contact the team if necessary to de-escalate it, or we've been able to confirm by our, reviewing of the charts, seeing the patient, assessing the patient, etc., that this parenteral nutrition order is appropriate. So if this is similar to how parenteral nutrition is ordered in your facilities, for those that are listening, I would highly recommend working really closely with the pharmacy department, and also having a well-written parenteral nutrition policy in place is very helpful. Something that explains, the workflow for ordering parenteral nutrition, how dietitians are involved, making sure that you're listing out the indications and the contraindications for parenteral nutrition. Make that all a normal part of parenteral nutrition ordering, so that way you can prevent inappropriate parenteral nutrition orders from getting started.
Well, Susy, you've shared so much, I think, great advice and like wisdom tidbits to help push nutrition along in the ICU. For our dietitians listening who maybe feel frustrated by underfeeding or inconsistent practices, what advice would you offer for driving sustainable change?
Yeah, so something I'm very passionate about. So for all my fellow dedicated ICU, amazing ICU dietitians, the best piece of advice I can really give is to consistently and confidently show up as a nutrition expert every single day. Because as the ICU dietitian, what you do isn't just it's not just supportive. It's quite literally life-changing. It's life-saving. And we have a background in science. We understand, what's going on in critical illness. We are the most knowledgeable on macro and micronutrient requirements, on parenteral nutrition, on tube feeding. So when you show up confidently as a nutrition expert to ICU rounds every single day, and you bring your specialized evidence-based knowledge to the table, when you contact providers and team members and you very securely provide them with your recommendations, when you speak up and you lead conversations on nutrition, you are proving to the team that you and your knowledge, they're integral, they're vital to the patient's healing. And when you do that, team members are not going to just trust your recommendations. They're actually going to know who you are. They're going to know your face. They're going to know what you do. And they're going to start going to you directly, and they're going to start contacting you directly whenever any nutrition related question comes up. They're going to know your face as the face of ICU nutrition. You are the nutrition expert in the critical care unit. And once they recognize you as that nutrition expert in-house, that's going to make you empowered to lead these changes, implement QI project, drive change. And you're going to see how these changes that you want to implement and that you do implement, which I highly, highly, recommend everyone implements any sustainable changes that are going to help improve nutrition delivery in the ICU. Like I've mentioned, when you implement them, because of the way that you've been able to confidently show up and the way that you've been able to show to providers how much you know on nutrition and what you could do to the team and how you can improve patient care. Everything you implement, all these policies you implement, protocols, new projects, everything's going to be smooth. Everything's going to be met with, great acceptance and great reception from everyone around you and everyone from the team. And it may take time, but when you show up confidently on the daily, be there, the team will recognize your value. They're going to recognize what you have to offer, and you're going to see how what you've taught them, what you've shown them, starts getting implemented. And eventually, you will prevent inadequate nutrition delivery. You will prevent inconsistent practices. So just keep working hard, keep caring, and walk into that ICU and walk into that ICU unit knowing that you are a crucial nutrition expert on the team.
Well, Susy, those words are so powerful. So thank you for sharing your expertise with us and really for all the work that you're doing to improve nutrition support for the critically ill patients. Your practical outcomes driven approach is really a powerful reminder of the impact that dietitians can have in the ICU setting. So thank you so much for being with us today.
Thank you, Christina.
And listeners, for more resources, education, and ways to get involved with the DNS community, be sure to visit our website at dnsdpg.org. Until next time, I'm Christina Rollins. Thanks for listening.